So we will get started today. So welcome everybody to our Department of Medicine Grand Rounds. We are delighted to have our first external speaker today, Dr. Pai, and he will be introduced by Dr. Daud Siraj, who is a professor in our Division of Infectious Diseases and our director of our Global Health Pathway. So with that, I will turn it over to Dr. Siraj.
Thank you, Lynn. It gives me great pleasure to introduce Professor Madhukar Pai as our inaugural Global Health Grand Round speaker. Dr. Pai is a Canada Research Chair in Epidemiology and Global Health at McGill University, Montreal. He is a director of the McGill International TB Center. Dr. Pai did his medical training and community medicine residency at Vellore, India. He completed his PhD in epidemiology at UC Berkeley and postdoctoral fellowship at the UCSF. After finishing his training in 2006, he moved to McGill University, where he moved through the ranks to become a full professor and holds this position that he is now, and also the title. Dr. Pai serves in many committees, among them on the SIG-IVD committee of the WHO, which is the Strategic Advisory Group of Experts in Vitro Diagnostics. And also he serves in the advisory committee of FIND, which is Foundation for Innovative New Diagnostics, and Access Advisory Committee of TB Alliance in New York. He serves as the chair of the Public-Private Mix Working Group of the Stop TB Partnership. He is on the editorial. In addition to this, he is an editorial of many journals, but among those, editorial board of the Lancet Infectious Diseases, PLOS Medicine, and also BMJ Global Health. Dr. Pai's research is mainly focused on improving the diagnostics in developing countries, with a special emphasis on diagnosis and treatment of tuberculosis in high-burden countries like India and South Africa. His research is supported by grants from funding from many sources, including Gates Foundation, Grand Challenge Canada, and Canadian Institute of Health Research. He has more than 300 publications. He's a recipient of the Union Scientific Prize, Chanchalani Global Health Research Award, Haile Debas Prize, and David Johnston Faculty and Staff Award. He's a member of the Royal Society of Canada and also a fellow of the Canadian Academy of Health Sciences. It is an honor for us to have you here, Madhu. The floor is yours.
Good morning, everyone. Thank you, Daud. Thank you, Lynn, for the very kind invitation to be a part of your Grand Rounds. I'm very honored to kick off your Global Health series. Before I talk more about the actual topic, I think it's important to say a little bit about how I'm approaching this particular topic of global health. I've always felt challenged in my role. Until recently, I was a director of global health at McGill. These pictures, if you can see on your left, that's me doing my residency training in India, where we did a lot of work in rural India. And when I was living and working in India and training in India, I always saw young white folks from US, UK, Europe come to our hospital, stay for a week or two or a month, do some small projects and go home and publish their work, while none of us got to publish anything. And at that time, I wasn't quite sure what that was all about, and I was not very happy. I remember talking about it to my own colleagues that our own expertise didn't seem to be very valued in the place we were, while foreign visitors who came on these short-term missions seemed to get more benefits than we ever did. And then fast forward years later, I have been responsible for sending many young Canadian students to India or sub-Saharan Africa to do global health projects. And I do ask myself whether I'm now a part of the problem in perpetuating some of the colonial style practices that made me unhappy or nervous when I was much younger. I think it's fair to say that I have seen global health from both sides. I've seen it as an Indian living in India, and I've seen it as someone who is now in a privileged position where I'm a full professor in a good top tier university in a high income country. And having seen it from both sides, I can see lots of potential for global health, but I can also see plenty of problems. And I think it is in this context that I've been speaking a lot and writing a lot about what is wrong with global health and what is it that we can all do to make things much more equitable and better. So in that constructive spirit, I offer you this talk, and I hope you will receive it as a constructive exercise, not as a criticism necessarily, because I see myself very much a problem right now because I now live and work like you in a high income country. So if you ask me, so what's wrong with global health? I think it's good to start off with the blue pill version of global health. By blue pill version, I mean the version that we would like to tell our students or write about in our papers, or the version that we might ourselves believe in, that this is what global health is today. I think the blue pill version will say something like, yeah, global health did come from a colonial past, but now we are in this much better, happier place. We don't have necessarily any problems worth speaking about. We are a lot more equitable, reciprocal. We believe in bidirectional learning, and we are far away from those colonial roots of global health. And this is indeed taught in schools, and a lot of young people get excited about global health in part because they think we have come a long way from these colonial pasts. If you ask me what is the red pill version of global health, then I will say, okay, let's look at the data together and then decide whether we believe in the blue pill version or the red pill version. So I'm going to show you a series of slides with data on what is the global health structure and landscape look like. So I've been writing about it, and you can read these in-depth pieces if you wish. They are all on Forbes. And as part of that series, I have written and I've looked at data. For example, who sets the agenda in global health? Who calls the shots in global health, and where are global health decisions normally made? And here, if you look at the Global Health 50/50 report that was released this year, you see a striking finding of the nearly 200 global health organizations that they surveyed. Nearly 90% are headquartered in North America or in Europe. In fact, US and UK alone account for the giant majority share of all global health organizations. So if you say, where are global health decisions primarily made, I would say it would be in Geneva, it would be in London, it would be in New York, it'll be in Seattle, it'll be in Washington, DC. It is not happening in Nairobi or Delhi or Phnom Penh or Kampala. That much I can tell you. The decisions are made far away from where the real problems and solutions are. Next, who runs these global health organizations? Again, wonderful data from this particular report clearly demonstrates that out of every 20 global health organization directors or board chairs, majority, almost 17, are from the high income countries. There are very few people leading these organizations in low and middle income countries. And there are very few women from low and middle income countries in any leadership role in global health. So global health organizations are primarily led by men, white older men in the highest income countries. Those are the data. These are not my opinion. They are the actual data. Who's financing global health? If you look at the global burden of disease data, it could not be clearer that a giant share of the global health development assistance money comes from the highest income countries. The United States is the #1 funder of global health, followed by UK, Canada, France, Germany, philanthropies like the Gates Foundation, so on and so forth. And all of us know that people who control the money also control the agenda. And that's why decisions get made far away from where the actual problems are or the actual so-called beneficiaries are. Who's publishing all the research in global health? Well, here a series of studies have been published, and the results are strikingly consistent. The best title I've ever seen to encapsulate this particular problem is the one by Bethany Head Gautier and others, where they said stuck in the middle. Authors from low and middle income countries, if they are on the paper at all, are usually middle authors, while the first authorship and the senior authorship invariably is taken up by people like us. People working in high income countries are the ones who dominate authorship in global health papers. Even if it's a problem that is entirely located in an LMIC, it is usually us who dominate the first and senior authorship position. Who edits global health papers? Work done by us and others clearly show that a vast majority of editors and editorial board members are from high-income countries. They're mostly men, and they're mostly located in the highest income countries. US, UK dominate global health journal editorial boards. Where are global health degrees offered and for whom? Again, we did a study on this, published recently in BMJ Global Health. And you can tell that the so-called master's degrees in global health is what we looked at. They're pretty much all located in North America or Europe. Although the intended beneficiaries are from low and middle income countries, most of the global health degree programs are offered in US and UK. And the tuition fee for an average master's degree in global health in North America would be in the range of $60,000 for the degree program. And we have to ask how many people from low and middle income countries can afford to pay $60,000 as tuition fees. So then who really benefits from these degree programs? Turns out that these degree programs primarily benefit students here in the north, not those in low and middle income countries. And to cap it all, you now have a series of reports of racism and white supremacy in many, many global health organizations. I mean, it's an endless series of reports from the Stop TB Partnership to the World Health Organization to the United Nations to Doctors Without Borders to Women Deliver. One after the other shows that racism, white supremacy is widespread among global health organizations. And schools of public health are also built on a very strong base of colonialism. If you look at the London School of Hygiene and Tropical Medicine, or any of the older tropical medicine schools that are still widespread, or even schools of public health as we see it, they're predominantly built on a colonial legacy. And this paper in Nature Medicine made the point that faculty composition of the top 15 public health schools is white at the top and Black, Asian, and minority ethnic at the bottom. You still have a huge problem of lack of diversity in schools of public health even today. And we know for sure that colonialism is not a historical issue. It impacts us every single day, even today. In the United States, it manifests itself through the very poor health outcomes of African Americans, whether it's the high rate of maternal mortality or the higher rates of COVID deaths. It's predominantly affecting Black Americans, while in Canada, most of our poor health outcomes are among the Indigenous people, where Canada's settler colonialism still plays out on a daily basis. So colonialism is not a historical issue for discussion. It impacts us every single day, even in North America, which is one of the richest parts of the world. So the key takeaways from everything that I've shown you so far is that every single aspect of global health, from where global health agencies are headquartered, to who runs them, to who funds them, to where decisions are made, every single aspect, publication, editorship, who speaks at conferences, where are conferences held, every single aspect of global health is dominated by people like us, people who are privileged, people who are in wealthy institutions, people who are in the north. Predominantly white older men dominate global health. Now, the manifestations of all of this, and this is just my hypothesis, and I put together this elephant graphic because I was trying to grapple with all of these various things myself, right? Privilege is obviously a big part of the story. Colonialism is part of the story. Patriarchy is very much a part of the story because, as I told you, it's mostly men who dominate global health. White saviorism is a big part of the story. Racism is a symptom of all of this, and white supremacy is a huge part of this equation. And I ask myself, okay, each of us is approaching this slightly differently. There are people advocating to decolonize global health. There are people who are saying women are missing in global health. There are people who are pointing out that racism is a big part of global health. And I ask myself, well, so what's the elephant that we are all trying to touch? And I think that elephant is power. Power is concentrated incredibly in the highest income countries among the most privileged people. And if we are not able to do something to dismantle this power structure, I really don't think we'll make any progress in global health. Global health is a story of power, dominance, and power. And yes, there is a growing movement to decolonize global health. And I've been giving multiple talks. Multiple people have been organizing series of conferences and discussions on this. It continues even today. It started at Harvard. Duke has done it. Harvard's done it. Edinburgh has done it. Georgetown has done it. UCSF is doing it. We're all starting to discover or learn how the power differential in global health is so deep and widespread. Now, the question is, what are we going to do about it, right? I think part of the issue is to just understand this dramatic power differential, appreciate the underlying global health architecture that allows power to be concentrated amongst people and institutions like ours, and then ask ourselves, is this what we consider fair, right? Is this fair? Is this equity? Is this diverse? Is this inclusive? And the answer will come back as a clear no. Now, if we believe then in that, what do we do to dismantle the power structures that confer privileged people more and more privileged? And I'm now slowly trying to converge at the idea that if people like us, and here I'm talking about men in the highest income countries in powerful privileged positions, I think we as a group must start seeing ourselves not as leaders in global health, but more as allies. Our job is to be supportive. Our job is to not take more and more power and accumulate it among ourselves. And so I firmly believe that those who are least represented in global health, that is, folks in low and middle income countries and women, must lean in, while men and people in the highest income countries must lean out. We have to clear out from the room and allow that room to be occupied by those who really need to be in the driver's seat. You can think of it as leaning out. You can think of it as passing the mic. You can think of it as sharing power and privilege. You can think of it as spending your privilege. One way or the other, this must happen because we are so leaned in right now, there is no room for anybody else to contribute in global health. So the conscious, deliberate act of leaning out is what we all should be practicing, I believe, if we are privileged and if we are working in high income countries and we believe in equity. If you don't believe in equity, then there is no need to even go down this path. But we cannot be double-faced. We cannot say global health is about equity and not challenge the power structures that are currently in place. So I now want to kind of close off by sharing some thoughts on how I think the pandemic might offer us a chance to reimagine global health. So global health is not in good shape. It wasn't in good shape before the pandemic. Will the pandemic put it back on track and take us towards a more equitable, fair global health? That's the question. So I wrote a piece on this and interviewed a lot of people. I thought a lot about it. And I could see, and others could see, that there are some positive things coming out of this pandemic, no doubt. But there are a lot of negative things coming out of this pandemic as well. Let's talk a little bit about the positive elements. So, firstly, I don't think anybody in the world now needs any convincing on why global health matters. We know that what happens in Wuhan will come to Wisconsin, right? So, the whole concept that we should care about global solidarity or that we should care about global health or international health is a strongly made case now, right? Even a child now understands why this is important. I think we also know by now the case is made for the fact that investing in health is investing in the economy, right? They are um, deeply interrelated. There is no point in falsely dichotomizing them. I hope we also now realize that universal health coverage is absolutely fundamental. You cannot have most people so vulnerable for the lack of insurance, for the lack of healthcare. And when a pandemic hits, that simply is not a tenable situation to deal with any crisis. You need a robust healthcare system that is accessible to people regardless of their ability to pay. We all need a safety net, is what we have learned in this pandemic. I think we are also learning that public health is very valuable, right? All these years we thought we could defund public health and everything will be okay. But now we've learned that we must invest in public health. It's often invisible, but it's a critical component of any country's health system. And then one positive issue is in this crisis, we are also inward looking now, right? We are just worried about what's happening in the United States or Canada or UK. We're not rushing off to save Africans from COVID-19. Africans are just figuring it out on their own. They are learning and they are self-reliant and they are probably doing better than we are doing here. So I think that is also a positive reflection that has come out of this. But the negatives are really scary as hell. I think the first big negative we are seeing is a complete collapse of global governance. Right now, none of us know who the heck is in charge. Who is leading the charge against this pandemic? Because this pandemic requires international collaboration that is completely unprecedented, right? We need to be sharing best practices. We need to be sharing vaccines. We need to be sharing information. And we know if a country suppresses information, that it is catastrophic for the rest of the world. But who is to bring all these countries and groups together? Who is leading the world? I'm afraid nobody is leading the world right now. And it's quite chaotic and anarchic. And I think the collapse of the United States as a global leader is painfully visible in this. Under normal circumstances, US would have led from the front. Under normal circumstances, US CDC, which wrote the book on what to do with outbreaks, would be helping the whole world figure it out. But we know that's not happening. And so I think the retreat of global health from United States from the global health arena is a very painful development, and it could have long-reaching consequences for how the global health architecture gets restructured. The second big crisis is US pulling out of WHO has set off a devastating chain reaction where other countries are also feeling empowered to blame WHO rather than themselves and defund WHO in the midst of a pandemic. And as the economies keep collapsing, even here in the US, in Canada, in Europe, I fear that our leaders are using this as an excuse to cut foreign aid further. Not just foreign aid, to cut refugee programs, to ban visas, to ban immigration. And I think this is a huge retreat from global solidarity. International aid is absolutely critical to keep many life-saving programs going. For example, if US cut PEPFAR, what happens to HIV/AIDS? Millions of people who are relying on PEPFAR for antiretroviral treatment in sub-Saharan Africa? What happens to Global Fund? What happens to Gavi? What happens to vaccination programs? So it's a matter of great concern that international aid might go down. Already we see that happening in US and UK. At a time when the need for aid has actually gone up. The pandemic has pushed millions of people into extreme poverty, right? The Gates Foundation and others have estimated that something like 40 million people have been pushed into extreme poverty in the last 8 months. And so the need for low-income countries to have more support has gone up. And I worry that the generosity of the high-income countries is dramatically going down in this particular crisis. And nationalism, isolationism, and xenophobia, it's almost at an all-time high right now. And I think vaccine nationalism is a clear illustration of how countries are only able to think about themselves, right? Buying up the whole stock of vaccines, hoarding precious products like PPE or other things, are all examples of unbridled nationalism. And that nationalism is a dramatic retreat from global solidarity. It goes against everything that we believed in, that we should think about the whole world, that we are all global citizens. This is an extreme example that we are starting to see played out right now. So even as COVID vaccines get developed, it is completely unclear at this point whether low and middle income countries have any hope of getting any of those vaccines, because the richest countries in the world have bought them all up. Very little is left over for the COVAX initiative that WHO and others are leading right now. And I ask myself, it's not just COVID. How will low and middle income countries recover from the devastating collateral damage that COVID is imposing on the whole world? There is no other better way to kind of capture the devastating impact of COVID on everything else. Gates Foundation released a Global Goalkeepers report a month ago, and the catchy single line finding is 25 years of progress in vaccines unraveled, pushed back in 25 weeks. We have millions of kids around the world right now who have failed to receive the basic shot in terms of vaccination. Malaria mortality is expected to double in sub-Saharan Africa in the coming year. TB, we've seen our TB control set back by about 5 years. HIV, we're expecting 500,000 additional deaths because antiretrovirals are not reaching people. We have the world now in the deepest recession since World War II. I mean, this is absolute devastating everywhere. People are not getting their insulin shots. People with diabetes or cancer are not being managed. We have millions of women who have not been able to access contraception. This is just overall devastation. And so low and middle income countries, basically none of these sustainable development goals for health are likely to be met at the rate this pandemic is evolving. And it's just the first wave, right? So COVID-19 is like this first tsunami. Then we have this recession, biggest recession since World War II. And then what if climate crisis is next behind that wave coming at us, and we are completely unprepared for this? So to deal with this, I think this is a spectacular example of how these problems cannot be solved by single countries. No matter how powerful or wealthy a country is, you cannot tackle global recession or a pandemic or a climate crisis by just putting ourselves and our countries first. This requires transnational collaboration of historic proportions. And the question is the world ready? It's almost like COVID-19 is testing the world on whether we can work together as humanity, not as America, Canada, or Europe, as humanity. Can we get our act together and solve this crisis? And I am not convinced at all that we are able to work together and solve this crisis. I'm not seeing it. I'm not sure if any of you can see that level of cooperation and solidarity. I mean, this picture breaks my heart This was my home for 7 years when we lived in the Bay Area. And to see this guy in a mask in the midst of this orange apocalyptic uh, forest fires related smoke makes you wonder about the future, right? I mean, both pandemic and climate crisis are beautifully illustrated in one photograph, and this is California. And this is not far away, it's already happening, right? So we got to do something to go back and rediscover the core principles of global health that we would like to see. One of allyship, that we are all allies and we want to practice global solidarity, that we want to think as global citizens with a global state of mind. And we have to engage with all countries. A pandemic anywhere in the world is pandemic for us. Disease or climate crisis anywhere in the world is a crisis for us. That level of global solidarity and allyship, I think, is required if we got to redeem ourselves and get back on track. So I just want to end on that note that I hope, especially those of you, those of us here, if we say we care about global health, then I think these principles probably will not come naturally. We have to work very hard at acquiring them. In other words, practicing allyship, whether it's in the context of racism. So if you're a white person, how are you a good ally to Black and people of color? If you're a male, how are you a good ally in the cause, in the fight for women's rights? Each of us have to really learn allyship and put it into practice, and we have to force our institutions to back us in these activities. It's not just an individual growth or reflection. I think that certainly helps, but we also need institutional policies to change, which will allow us to be good allies in global health. For example, if we are not first authors, but if we played a supportive role in a paper, in a global health paper, that should be also considered valuable. It's not just about us and us getting the money. If we share the money, the grant money, if we share authorship, all of that should count as a positive thing on our CV and not be seen as a negative thing on our CV. So there is the personal part of this solution, and then there is an institutional part of the solution. I'm happy that these sorts of grand rounds and series on decolonizing global health or racism and global health are starting to appear a lot, especially after the Black Lives Movement struggle this year. And I hope that we can go beyond just waking up to actually doing something in terms of concrete steps in the coming years to bring back global health to some level of equity and fairness. Thank you so much.
Great. Well, thank you, Dr. Pai. And I'm hoping to and a little bit more provide some optimism, perhaps. And can you share some specific tactics that you have implemented at McGill University, for example, to help move this field forward?
Thank you, Lynn. That's a great question. So I want to first start by sharing what I have personally done. It's not just university. I think it needs to start with me. So, for example, I now, when I have global health partnerships, most of my partnerships are in India, and we write a paper together. For example, we've done a study. I make sure even if one author from here is the first author, let's say a student who did it as a thesis, I make sure the senior author is my collaborator from India. So that way it's an equal credit that both of us are sharing, right? Secondly, when I'm invited to give talks, I say, no, I don't need to be on this. Can you invite someone from the global south who knows more about the problem than I do and cede my mic to them, which I think is another concrete activity. Next week, I'm on a panel entirely to speak about male allyship. What is it that men can do to kind of relinquish some of their power? And that may for example, I was on a editorial board of one of the Lancet journals, and I wrote to them saying that I'd like to step down and I'd like you to replace me with women of color from low and middle income countries. They not only accepted it, they replaced me with 2 women of color from Africa and Asia. To me, these are small but critically important ways by which we can say we acknowledge the deep imbalance. We are trying hard to move it. In the long run, I think universities like mine, like yours, must increase faculty diversity. And right now, the diversity numbers are not great. I'm not sure about yours. I know for sure my university has a long way to go. For the number of Indigenous people in Canada, we have zero Indigenous professors in my school. And to me, that's unacceptable. We've got to fix these structural issues. So that's why I think I see the solution more as a personal, what I can do myself immediately without anyone helping me, and what my institution and organizations have to do. And I think the same thing has to happen in all global health agencies, whether it's WHO or whether it's the Gates Foundation or whether it's USAID. They have to look inside and say, are we diverse? If we are talking about global health, do we really have the voices around the table of people who are most impacted and make sure that they are in a driver's seat? Right now, it's far away from that.
There's a question from Dr. Siraj about what is our role of training the next generation of faculty of physicians and scientists? And are you seeing more curriculum around global health in programs?
So, global health continues to be the most exciting program for students, I think, in North America. They're very inspired. My own Global Health 101 course at McGill gets sold out within minutes. I've had to increase my class size to 150 every year. So I keep wondering, why are young people so excited about global health today? I don't have a good answer. I think I do know, for example, this pandemic has made them more aware of how interconnected our destinies are, right? So they want to learn more, they want to contribute more. I think young people also tend to be a lot more socially conscious than the older generation. They believe in social justice and they want to do something about it. So that's great. I'm very happy that young people are excited about global health, but I also don't think we should sell them this version of global health that we are the ones who are going to save the world. I think we have to kind of retreat from that and teach them how deeply imbalanced global health is, what its historical origins are from colonial past, and then what can we do today to redeem ourselves. So in other words, my global health curriculum began this year with an entire lecture on colonialism by a woman of color in Africa. Then we had an entire session on privilege and allyship and anti-oppression. And we're going to have a whole section on racism and then how it links to indigenous health. So in other words, global health curriculum needs to become a lot more critical, needs to be a lot deeper than how I think we've been teaching it. So all this decolonizing global health events that are happening around North American universities and European universities are primarily led by students, believe it or not. It's not being led by faculty, it's being led by students, which I think says something. They're not happy with what version of global health is being taught to them. They're asking much deeper questions than I think the adults are asking. So I think to meet that, we got to rethink how we teach global health. And then lastly, when I learned I was going to teach my large 101 global health course this fall online, I was very depressed at the start. I said, oh my God, how am I going to teach 150 students, undergrads online? Then I asked myself, okay, this is a crisis. I have no reason to hold on to any old ways of teaching. So I'm going to completely break apart what I've been doing for the last 5 years and reimagine my course. So what I did was I went crazy and invited people from around the world to teach in my course. Exactly what you were saying, Lynn, that we can afford to do this, and that's a silver lining in this crisis. So 70% of my course speakers are Black, Indigenous, and people of color. Nearly 1 in 2 of my teachers are from low and middle income countries. And I cannot tell you what a big impact they have made on my students and me, because I don't now need a local person to translate global health. We directly hear it from people who are battling these issues at the front line. For example, last week on Tuesday, I had 2 talks, HIV and TB. One was given by an HIV expert from Kenya. The other was given by a TB survivor in South Africa. Now, how cool is that, right? To hear it directly from people who know what the hell they're talking about, as opposed to us saying something about what's happening in Africa. That is night and day different. So all I would say is we can afford to decolonize our global health curriculum. And to be able to do that, students need to see real global health experts who are living the problem and dealing with it on the ground rather than people like us. I'm not saying we don't know anything, but I'm saying let them hear it directly from the source so that they go home seeing diversity in the classroom, they see diversity on the curriculum. If it's just a bunch of 10 white professors teaching global health, I'm sorry, but I just don't see how that's global health. It's a translation of global health. And therefore, we need to cut out all of us who are in the middle and directly take our students to where the problems and solutions lie.
Great. And speaking of students, for the residents and trainees who are listening, I am expecting some questions from you in the chat box. So just FYI, start thinking. In the meantime, one of the questions has come up of the realities of promotion in academic institutions, particularly for our junior members, where currently the coin of the realm is authorship on papers, first author or senior authorship. So how do you influence and make changes in some of those institutional structures that allow, that reward more sharing of responsibilities?
It's a great question, and I am unfortunately in the same shoe as all of you because our promotion and structures here are very much to do with how much money we got to the school, how many first author or senior authors papers we have, and it will take a sea change for us to accept that we could be good allies and that could still count as part of our global health work, as service work, even as research work. So maybe in future, there will be a section on our tenure or promotion dossier which says, explain how you were a good ally in global health, right? It's like men should be asked that question in their evaluation. How are you a good male ally for your women colleagues at your university or globally? Did you sponsor women? Did you promote them? Did you mentor them? Did you give up your spot for them? Did you, bring them up the promotion chain? I think allyship is so fundamental for everything I'm learning. I did not actually learn that word until recently. And now, having taken an entire workshop on allyship, I cannot tell you how incredibly powerful that concept is. Right. So if we are being evaluated for our work on, say, diversity in our school, I think this question should be asked of all white people. How were you a good white ally in the fight against racism? What have you concretely done in terms of building diversity, promoting people of color? I think that is the same way of thinking about global health. How am I a good ally for my colleagues in low and middle income countries if I believed in equity, right? And there has to be a way for me to even describe that in my promotion dossier. Right now, we love things like H-Index. How many $1 million of grant money have you brought in? What awards have you received? But it's not about the team. It's not about reciprocity. It's not even about how many young people from low and middle income countries have you brought to Canada to train, right? I'm only asked how many students have I trained, but there is no expectation that I will actually contribute in global health training. I think this needs to really be brought into our way of thinking. And I'm not saying it's easy. I just don't see it's easy. Part of it is because many of us have not woken up. They have not seen the data that I have shared, for example. And when you wake up people and they realize, oh my God, this is so imbalanced, then it helps, I think, for them to understand, okay, we can and should do something to even out the playing field.
So I'm going to extrapolate a little bit of what you said, because I think what I'm also hearing is that the senior leadership needs to understand this, and it's the senior leadership that needs to influence institutional policies that allow our junior faculty to truly share in responsibility and be rewarded for that. So we need to be influencing institutional policies.
Absolutely. And senior older men absolutely must give up power. This is very hard. And I can tell you, I just can't understand. For example, women in global health is a big movement right now in the United States and everywhere. And they keep on hosting these meetings saying women are missing, women are missing, women are missing. I'm like, okay, when you have these meetings, how many men are there in this room? Well, hardly anyone. I said, that's a problem, right? Because men are the ones holding so much power. And if men are completely missing from these women in global health meetings, fundamentally nothing will change. So men have to relinquish power. And that requires men to wake up and realize something is fundamentally wrong, that they have enjoyed centuries of privilege, and it is time for them to relinquish some of that power or share some of that power. And it does not come naturally. We've seen that in the elections. We've seen that in how the world is structured. It requires a dramatic shift in thinking. So I'm just excited that there is even a panel next week at this Women in Global Health Conference on male allyship. And the panel is called The Art of Leaning Out. At a minimum, I'm not saying younger men can lean out quickly because they are wanting to make their mark in life. They want to kind of get ahead and get promoted. But what rationale is there for an older male who is very accomplished, has 1,000 awards on their walls, has every known grant possible, and has a CV with the H index of 150? What do they lose by sharing some of that? I would say nothing. They stand to lose nothing, and they can and should model it for others, is what I'm saying.
So Dr. Siraj, next year's lecturer will be a woman from a low and middle income country.
Yes.
We'll start thinking about that.
Absolutely, 100%. It's possible. It's doable.
Yeah, absolutely. So let me get to some of the other questions. So in the setting of a pandemic, much of our active research and clinical collaborations from a global health standpoint have been paused due to limitations on travel. So what can we be doing now to push some of those initiatives forward?
I think in some ways, I don't know whether this is a blessing or whether it's a curse, that we are not running around Africa or Asia or Latin America right now. And I think people there are trying to figure out their own best practices, their own ways of dealing with this pandemic. I have mixed feelings about it, and I wonder whether this pandemic is in some ways a good hard reset for how things will get done, right? So as opposed to someone from Madison or Montreal going and doing a research study in Uganda or Rwanda, would it be fine for us to play a supportive role from here? But the folks on the ground are the ones figuring it out and leading it, and they end up becoming first authors, and we might be middle authors, and so be it, right? That might be the right thing, and that might be a silver lining as well.
So leverage telemedicine and telecommuting to help support research, active research in LMIC. Yep.
That's exactly right.
And so the next question is, white saviorism is a real issue. Do you think just sharing leadership roles and expanding cultural competencies will actually completely resolve this issue?
Well, it's a tricky, complicated question, and I was discussing it with someone this morning, actually. Let's take global surgery, for example. There are so many surgeons. I don't know about your school. I know for sure it's in my school at Harvard and Duke and everywhere else. There's so many surgeons who are keen on global surgery as an area of global health, right? And I see that as one area where white saviorism is still deeply problematic for me, right? It's like this white surgeon going off into Africa to operate on fistulas or operate on cleft lip or palate, these mission-driven surgeries where you line up everybody and I'm going to come for a week and I'm going to operate. I think that field is slowly waking up, and I think they're asking these exact same questions. Another group, which actually shook me to my core, was Doctors Without Borders. Did you know that this year they were called out for institutional racism, which is like an awakening that they never had before. And they admitted that they are structurally built on white saviorism and white supremacy, because that is the origin of MSF, right? It's a bunch of French white physicians who decided that they want to go save the world and get into crisis and conflict situation. Now, can you imagine if agencies like MSF are having these internal conversations on white supremacy and saviorism? They have to diversify. There is simply no other way out. If MSF continues to be dominated and led by white physicians from the North America and Europe, fundamentally MSF will continue to be driven by white saviorism and white supremacy. There is just no way around it, because that is how the structure is built. And that is where I think dismantling structures will be critical. Just like WHO, for the first time, had an African as their director general. That is remarkable. I mean, that's like a glass ceiling that was shattered after, I don't know, decades, right? So things can happen, things can change. For that to happen, you need to have actual real diversity, not just people saying, yeah, we understand that this is an issue. I think tokenism is obviously the first step that a lot of people will do. Put one person of color on the committee or have one author from some country. But to go away from tokenism to a meaningful change will require dramatic structural changes. But for structural change to happen, individually, we need to change as well. Because if an individual at the leadership is able to see this, then I think they can do a lot to change the structure as well.
Okay, well, I think we're getting close to our completion of the hour. I do want to very much thank you, Dr. Pai, for coming in and giving us a different view of global health. I actually think it is relevant not just for global health, but academics in general. Although you are not here, you have an open invitation to come back to Madison at any time. And we would be handing you the plaque, thanking you for your participation. You will be getting it by mail, and Dr. Siraj will be including some cheese curds to give you a flavor of Madison. Thank you to come back.
Thank you, Lynn. I really wish we were in normal times that I could have actually come and done something with you. But thank you so much. I'm deeply appreciative of it. It takes courage to even organize grand rounds which challenge traditional ways of thinking. And I'm sure I've made some people uncomfortable with what I have said. But lack of comfort is necessary sometimes to wake up, right? And we need to be shaken up. I think what happened this summer with Black Lives Matter is a landmark moment. It has made a lot of people bold enough to query or challenge what's going on. And just as that is happening, the same thing is happening in global health. More and more people are asking what is wrong with global health and how it is being run. And this decolonizing global health movement is well underway. And the women in global health movement is well underway. These will all have to converge, these various movements. And I think they're all built on the exact same underlying power imbalance. And the sooner we understand that animal, the more I think we can dismantle it. So thank you so much for your courage in opening the doors for these difficult and uncomfortable conversations.
Yes, absolutely. Department of Medicine fully supports delving into this and working to make the world a better place.
Thank you.
Okay.
Stay safe and have a good one.
Thank you all.